screen because, well, perhaps first of all, who actually attended my talk yesterday, hands up. And who can tell what is different with me today? The voice? Well, still so sexy, but anything? My bow tie. Right, and my shoes. If you cannot distinguish this difference, then you have to come closer. Anyway, and I still apologize, my voice is still too sexy. And I try everything, you name it, all the cough and cold medicine. So if I suddenly get high and do the K-pop, so you have to, give me, claps. Anyway, all right, so those who are actually still coming in, please come towards this front. And I do notice that the tables are a bit different, and you guys should be very cozy. All right. Okay. So today the talk is this skin cancer? So many a time when a patient comes in, either you ask yourself whether this question, a voice in your head, or you actually patient asks this question. So this is a burning question. And again, a bit of a disclaimer, a little bit of introduction for those who haven't been to my talk. I'm not a specialist dermatologist. I'm a focused practice dermatologist practicing in the jurisdiction of Ottawa. And I used to be a faculty at Queen's for 10 years. And during that 10 years, 2007 to 2017, I maintained an interest in dermatology, and I keep running a few talks for the PGY and PGY2, and they all culminate in this talk, and basically letting the PGY1 and 2 know what is going on in dermatology. Interestingly, I must say that when I was a student in England, I remember my teaching is a bit more comprehensive. That's why I try to fill up the gap here. For those who are actually in practice long enough, you do know that skin is something which is a big black hole, right? And sometimes you either prescribe something for the sake of the patient or for the sake of your peace of mind, but is it really good? And this topic is very important, okay? So. Okay, conflict of interest, I'm no longer faculty, I have no grants and research support, and I have no honorarium doing this talk. I have no patent in relation to the topic, no funding, so forth. And I said I'm not FLCP's dermatologist. I've got the CCFP, I've got the FLCGP, I've got the FACGP, specialists in 3 jurisdictions. Now a bit of preamble. Those who actually read the news, we know that actually this morning, that lady talked about even 1/3 of Canadian no family physician. Actually, half of a Canadian have no family physician, and that led to severe kind of consequences, mainly in skin. Okay, skin already is a relatively less taught subject, and with a delayed access to family physicians, definitely led to a rise of melanoma and in some, not just melanoma, but invasive skin cancer. All right, and if you read this paper, the link that I have it here, actually there is a relative lack of knowledge, not just in our country, but across the board in America, also led to delay in diagnosis. And yes, COVID-19, remember the fabulous COVID-19, make everyone incarcerated, don't want to come out of their home, and there's kind of like a situational barrier of access to care. And if you read this paper also, this actually causes delay in diagnosis invasive melanoma. So these are preamble. Now this is the summary of the presentation. I'm going to go through quickly what is skin cancer, feature of skin cancer, but there are so many skin cancers I can talk about. So I'm going to list the 3 commoners, namely basal cell carcinoma, BCC, squamous cell carcinoma, SCC, melanoma, and the others, and some mimicers, what I call, and then how to diagnose. Okay, so I hope that will actually be good enough as something to share with you. All right, so what is skin cancer? I'm going to make it very simplistic because I'm a simplistic person, right? So basically, just like any cancer, a cancer cell is your own body cell that got out of control. The control is the recognition to inhibit unending growth. So any ethnic cell tissue that lost intercellular recognition to the point that they become foreign, and then they invade or starve or compress the other adjacent cells. And this does not conform to any cell matrix pattern or boundaries. And also, some of them being malignant enough, they are undifferentiated, almost like the stem cells, okay? And they are immortalized. They cannot be killed. They live forever. And that's why they metastasize, either through the lymph system or the blood. And then, of course, for some obvious reason, they are so rapidly dividing, or they are so clever enough, they change their outer coat. The cancer cells, they don't have the usual cell receptors that can be recognized by the T cells, the killer cells, whatever, and they just go around, unnoticed. And that's why they can spread and they can kill. Now, before, as we say, old saying, before we know the abnormal, we have to know the normal. A little refresher from the source here, I took out the histology of the skin. The outermost layer, the stratum corneum, which is dead, dry, dead skin, which shred every day. And then, below that, we've got the stratum granulosum, stratum spinosum, and that makes the first layer, which still lives, okay? And that actually, in a minute, I'm going to tell you, that is where the squamous cell comes from. Further down, you get the stratum basale, which is where the basal cell comes from. And then finally, look at the little gray little guy, melanocyte. And that is a culprit for melanoma. If they go uncontrolled, if they go divided beyond kind of control. So features. Technically, we are all, experienced enough. If we see something which is out of the extraordinary, or something that, is not pretty at all, then that should actually sound a little alarm bell in your head and see whether this is skin cancer. But are they really all skin cancer? This is why you're here to, that I can share the knowledge with you. So, in general, features of skin cancer. If you see something, a lesion, what we call the technical term, if you do a referral to dermatologists, please use the jargon, the lingo, okay? They will love you, okay? Lesion means any skin kind of, abnormality called lesion. Any lesion which is of unusual form, shape, size, color distribution, lack of symmetry. And in particular, we would like to concentrate on the edge, whether it's spread, whether it can be well defined, or any symmetry. I like to do a 90-degree diagonal kind of cross. If you can actually either bisect a whatever lesion and then roughly symmetrical, then probably you won't say that it's asymmetrical. And the size, usually the rule of thumb, there's no hard and fast rule. Any lesion more than 1 centimeter and it's been growing, it causes concern. Color can be increase in color or loss of color, okay, especially in melanoma. Don't think that a mole that actually lost color is something good. No, not necessarily. Okay, distribution. 1 become 2, 2 become 4. This satellite lesion called spin-off lesion. Lack of symmetry I talk about. Onset and duration, okay. Now, sometimes the quite often patient get referred to me and then they say, I have this mole for 30 years. It's just looking odd and I'm not taking any attention. Please correct the patient. Anything that they have for 30 plus years, there's not a guarantee. They can go bad, okay? So you have to nicely correct the patient and correct the doctor too if they think this way. So don't presume. It can be acute, it can be chronic, acute and chronic, okay? Changes I'll talk about. And then, if possible, try to take pictures. I'm not sure what EMR you're using, not to, advertise, but I use the TALUS, which is very good. The Med Access, which allowed me, especially in my practice, focus practice, they allow me to upload pictures, and it's very good. And then I can do a serial kind of comparison, okay? And it's good that, especially if you want to refer patients to me, I would certainly appreciate you send me some pictures in order to triage them. Please don't just send me, see this patient with a mole. Send this patient with a rash. All right, I know you are busy. Everyone is busy, but let me try to triage the patient. Okay, I time and time to call the patient and ask the patient send me a picture in order to know what is going on. So please, when you send a referral, we appreciate more descriptive kind of words. Red flags. Contact bleeding. Now, bleeding without pain, this is actually a red flag, okay? Especially when you see the lesion is kind of like non-healing, granulating, and it's been there for a long time, the ulcer doesn't heal, and it's painless. Now, I would rather be an ulcer be painful than painless. Bear that in mind, okay? If it's a painful ulcer, this is a healing ulcer. You still got the nerve. But remember what I said to you. If it's a metastatic or invasive cancer, it already killed the nerve. No way, Jose, it will actually be painful. All right? So a painless bleeding ulcer, bingo. If you kind of elicit that history, send it to me, I will see the patient the next day. Poor, no response to treatment. Yes, you can give some cream if you suspect some kind of infection, give some fusidin, whatever, but don't actually give steroid in a minute, okay? Again, echoing what I told you. Steroid for melanoma, for cancer, doesn't actually work. In fact, it will further, it depresses the immunity. Put some moisturizer, put some fusidin or something like that. Not fusidin, some Vaseline if the lesions start to bleed. And then the features, the risk factors being age, if the advanced age more than 55, actually, this is just a rule of thumb. The earliest skin cancer patient melanoma I've seen is 22. Okay, so again, don't presume. Irradiation, history of irradiation, chemotherapy, immunosuppressant, a lot of patients on Humira, Stelara, then they get referred to me to see whether there's any early squamous cell carcinoma. Yes, I do pick up some of them. Chemical exposure, especially aromatics, benzene, ring compound, arsenate. And then genetics. Now, Fitzpatrick type 1, very fair skin. Some patients have the disseminated superficial actinic porokeratosis, DSAP, which is a very rare condition, also predisposed to SCC. And then in the literature, the CDKN2A, also a gene, kind of a genotype that will lead to increased skin cancer. UV exposure, by far. Most patients have squamous cell. They have overexposed themselves in their earlier years to the point that they got sunburn. How many of you actually heard the story that, young people, young children 40 years ago, they were told to stay outside with some baby oil and don't come back until they fry like a fish? Yes, I thought it was a joke, but it was true. And those people I'm seeing now, when they're in the 60s, they got actinic keratosis, Bowen's disease, and SCC. I'm going to show you. So ultraviolet exposure, it will come late. They have to pay the debt. All right, the statistics. So the prevalence in incidence. Now, if you look up the Canadian Cancer Society, they cannot give a correct statistics as to the non-melanoma skin cancer because it goes as a spectrum. And even I do not actually feel the compulsion to report them, so they are not accurate. But roughly, for the data that they have collected, we know that basal cell actually, as compared to squamous cell, the ratio is 3 to 1, roughly. And then 1 in 8 lifetime risk for basal cell, 1 in 20 for squamous cell. These are the Canadian statistics, by the way. And then 5-year survival rate, both are higher than the melanotic type of skin cancer. Now, talk about melanoma skin cancer. This is the more malignant type with a lower survival rate. And the incidence in 2020, because it's usually a hospital kind of, management, they do keep a registry. And it was told that in 2020, there were 9,000 new cases. And the male to female ratio, roughly the same, 4.9 to 4. All right, so at this juncture, I'm going to start talking about the common type of skin cancer, the basal cell. Again, this is the commonest type of skin cancer. And then again, it's uncontrolled growth of the basal cell. And it grows very slowly, usually takes 6 months to a few years. And rarely, if ever, they will metastasize. But it can be locally invasive. In the country I was trained in England, they used to call it rodent ulcer. Rodent means rat. Ulcer means a little nasty ulcer being chewed off, the skin being chewed off. So we can imagine this kind of, why they call rodent ulcer. And if you look at the literature broadly, they are divided into 4 histological types. The nodular type, which is very common, the superficial spreading type, which is quite difficult to diagnose. Sometimes even I would mistake it as a actinic keratosis. And then sclerosing type, the scar type, cicatricial type, very challenging to diagnose too. And then the pigmented type, also sometimes confused with moles. Now again, I will record this diagram. So the basal cell, we're talking about this layer, stratum basale, the basal cell, or the stratum spinosum, carry different names. So it's actually quite deep. Right. This gentleman, okay, what follows are all true pictures from my patient having, authorization to use their pictures for this talk. He said that, well, I've got poor fitting glasses. This actually thing, the little pack, this nuisance sit on my nose and never healed. And I said, how long has it been like that? About 6 months. And is it painful? No, not really. And does it bleed easily? Yes. Dermatoscopy. Now, I do call out again those who like to advance their knowledge, go to the talk for the other two doctors. I don't know them, but I found that they are doing a spy with my little dermatoscope or something on Saturday. So this is a very good technique or tool to keep it in your clinic or learn about it if you are really passionate about skin. So dermatoscopy already showed that. This is a red erythematous ring with a clearly scabbed center, and those dilated blood vessels, we call them telangiectasia. Unmistakably an ulcerated nodular BCC. Okay, treatment basically depends. If it's so big, I can mitigate it with some liquid nitrogen, 5 cycles, 2 seconds, but then eventually I have to send to the plastic surgeon to cut it out. And plastic surgeon either do a excision with a skin flap or they send to Mohs. In my jurisdiction, there's only one dermatologist who are trained in Mohs surgery, and she will do the fantastic thing to get rid of it. Already you can see, very not pretty. In fact, scary, right? This parent said, oh, I've got this mole, and then another thing just came on. Maybe it come from a mosquito bite. I didn't pay attention. Oh yeah, because of shaving. So you can see that he actually avoided area. And then dermatoscopy show that, yes, on the upper part there is a similar lesion, a nodular thing with a volcano-like thing with a scab and a dry blood. And then next to it, what is that? That is a mole, right? And do you think it's benign or not? Shout out, please. I was told that 20% has to be interaction. Yes? No? Yeah, it's a lentigo maligna. He actually have double whammy. He had a kind of like a early kind of dysplastic kind of change. So I sent him to the surgeon, and he had a big piece of skin being cut out and kind of skin flap. Melanoma, early melanoma in situ. Lentigo maligna is actually also considered as a melanoma. Now about this. Eczema, right? No, sorry. Won't tease you. Psoriasis, right? Nah, not really. Look at the edge. Not really well defined. And what's happening is, you see the scar, right? And when you ask the patient, well, what happened to the scar, the white part? They say, oh, it used to be red, but now it's white. Okay? And then, is it painful? Not really. So I actually, to be honest, I confess, I'm not too sure whether this is, I'm betting my money on either SCC or basal cell. I actually bet it more like a SCC, but definitely a kind of biopsy. I took a biopsy, and it came back as infiltrated BCC. Okay, fair enough, but it's, yeah. And again, patient sent to the plastic surgeon to cut it out. So at this juncture, I mean, I won't blame anyone who cannot make a distinction between BC and SC. I actually need the biopsy to confirm. But it's straddling between the features between SCC and BCC, this one. Now, an old lady say that, oh, I have this spectacle, these glasses which are annoying, the leg actually presses so much. I had a little infection, never healed. I said, all right, let's have a look. And then I look at it. There's not much to see. So I fish on my dermatoscope, and I saw this. All right. So I'm going to describe to you with the scale. It's a 1 centimeter oval kind of papule with a very shiny cystic surface, partially ulcerated with scabbing and actually contact bleeding, obvious telangiectasia, and a bit of pigment. So I put all my money on a nodular pigmented BCC. Yeah, it's actually ulcerated. Pigmented sometimes don't get caught out. It's not a mole. Okay, so my guideline usually look for blood vessels. If you have a ginormous blood vessel, you bet your money on BCC, you can't go wrong. So this is a basal cell. And I sent to the surgeon. I can't do anything. Probably, again, I remember I medicated with some liquid nitrogen until she got referred to the plastic surgeon. I'm blessed in my locality. I have a very good associate. We don't work in the same clinic, but she's very good. Every time I send her pictures like this one and this one, she'll see the patient next week. The pseudoephedrine make me so dry. All right. Okay. This one. She said there's a mosquito bite that never heals, never goes away. Okay, both of them. And then again, the history is 6 months plus, painless, never goes away, sometimes bleed. So again, it's not ulcerated nodular basal cell, and this one is a bonus, pigmented nodular basal cell. All right, you might ask, how can I tell whether it's not melanoma? Well, no, I cannot tell, but this is something definitely need a biopsy. How about this? The patient claimed that he had it since COVID injection. He had exactly at that site a COVID injection, and it's a scar. And this story was echoed by the family doctor too. I said, that's strange. Anyway, so given the face value, and the of course, this patient has a history of melanoma in the family. I said, is it melanoma? So I have a good look, and I look at it. So what do you guys think? Fairly well-defined edges, a bit of pigmented domain at the 7 o'clock with a bit of scab in the center, and the unmistakable telangiectasia, right? Yes. This pigmented BCC is proven by biopsy. I was actually a bit on the fence whether it's a melanoma, and I tried to explain to the patient, I don't know why the patient is trying to sue COVID, the Janssen, whatever, causing the melanoma, but I told her adamantly it has nothing to do with it. Okay, maybe a haphazard kind of finding, but yeah. I think till now no study have ever shown that COVID immunization causes basal cell. All right, treatment. Very simple. Liquid nitrogen. Hands up those who have liquid nitrogen in the clinic. Yes. Hands up who got the Brimil spray gun. Yes. Please, spend $800 and get it. That is the industrial standard. Please don't ever use Q-tip. Okay? Q-tip is actually not, you cannot control the thickness that you're going to cryo. And it's not kind of, it's not constant. It's not the dose you apply is not good. So I would actually use the needle tip. Those you spend $250 more to get the needle tip, very small, and then you spray right on. 5 long cycles, 2 seconds, 3-4 freezing and thawing cycle, and then you can actually mitigate the lesion. Sometimes the lesion is early, you can even remove it. So Brimil spray gun, I'm not associated with Brimil, but that is the industrial standard thing that I use in my clinic. Forget about Q-tip, okay? Now, chemotherapy. Yes, study says that the Efudex is actually useful. Topical every night for 2 or 3 weeks. And then the imicramab, which is the Aldera too. Surgery, I talk about either wide localization with flap or moles, and has to be referred to the skin cancer surgeon. I don't know what the system in your jurisdiction works, but I think the quickest way is to do a biopsy, prove it, and then whether there is a skin cancer clinic in the hospital around your area or any plastic surgeon, they'll be more than happy to act on it fast. If you just send them to them, some of them actually, with a paper, they actually don't know whether this is the real thing. So probably do a biopsy if possible. Electrodesiccation means a hybrication and a curettage. It's a form of Mohs surgery, but it's more crude. Radiation. Sometimes if the basal cell is very big, sometimes you cannot excise it, even with a skin flap. Once I saw this when I was doing attachment, how many years ago? 2004. I was volunteering to do some 6 months in China. And this poor Chinese farmer actually come in, who walked 15 miles to see the only clinic in the area. And he was wearing a shirt, and lo and behold, he uncovered this dinner plate size ulcer. And it was a basal cell. And the dermatologist, the chief, actually decided he cannot be excised. Obviously, there's no big piece of skin that can be patched up on the chest. He ended up having radiation, which actually works in a way. Laser photos, these I put in parentheses because I don't know much about them, and if you like, you can read about it, but these haven't entered the mainstream yet. Mainstream being cryotherapy, chemotherapy, surgery, Mohs, and radiation. Immunotherapy also hasn't been in the mainstream yet. Prognosis, as I said, usually good. It rarely metastasizes, and as I told you, it's called a rodent ulcer. It's a localized ulcer. 5-year survival, according to this study, it's 100% if you clear the margin effectively. Now, the common misdiagnosis include infection, okay, because it looks ulcerated. Like if you have been putting something, in an elderly, treated as an infection for 2 weeks with Filcidin, polysporin, you name it, never goes away, then you should click. After hearing Dr. Leung's talk, please think of basal cell. And then Mohs, okay? And then eczema. Look at the superficial basal cell. Yeah, I won't blame anyone if they misdiagnose as eczema. Again, if you treat it with your whatever steroid, emollient doesn't work for 2 or 3 weeks, and then history has been 6 months or so, think of a basal cell, psoriasis and keloid. Right, on with the squamous cell. Right, squamous cell is the second commonest skin cancer. Is again uncontrolled proliferation of squamous cell layer. It's often painless and scaly and bleeds easily. It starts with actinic damage, sun damage, progresses to a keratotic phase, and then Bowen's, and then SCC in situ. It can be locally invasive with a metastatic potential. And the risk factor being if you have P55G mutation, and then other things like solar damage, chronic inflammation, smoking, immunosuppression, then you are more at risk. That's why I told you about some patients on the Humira, Stelara, they get referred to me for a skin survey. Now, by far the biggest culprit, the baddest guy is the actinic damage. Not recently, not 5-10 years. Because patient will swear to broad daylight, oh, I haven't been in the sun for the last 5 years. No, I told her, no, when you were young, when you were in your, very good shape with bikinis, and, you remember and say, oh, yeah. Keratosis, Bowen's and SCC in situ. This is the progression. And at this juncture, has to recommend sunscreen 60. Okay? 20, 30, pretty useless. I know there's a lot of controversy about sunscreen more than 30 being useless. Okay, my take is you have to use as high as possible. Don't go beyond 100 though. I do believe beyond 100 is a gimmick. Down south in America, they have 80 or 90, but in Canada, the highest you go is for 60. SPF 60, whatever brand, they are equal in protection, but you just have to choose whether it's a mineral or the chemical. I'll come to that in a minute. And the precursors being leukoplakia, changes of white patch, DSAP, cutaneous horn, and keratoacanthoma. These are also precursors of the squamous cell. Right, the diagram again, and we're going to talk about this layer. Okay, stratum granulosum, the top layer. Still with a nucleus, right? These are the cells that can multiply, okay? Without nucleus, they are dead. Investigation, of course, dermatoscopy, I told you, biopsy. When the squamous cell is bad enough, sometimes the hospital cancer specialist might do some lymph node sampling, and then even CT, MRI. And then treatment, again, if it's early, I say early, right? Actinic keratosis, even pre-Bowen's, I use some cryotherapy. And then Efudex plus Davonex. And then some electrodesiccation. And then Mohs surgery. And surgical section, skin flap, radiotherapy. Right. Going to show you a barrage of squamous cell as compared to the images you see in your brain, hopefully, as compared to basal cell. In general, if you ask me, they are more diffuse. The edges are not that clear, and they are polymorphic or pleomorphic, scabbing everywhere, some areas scab, some area red, some, so you can see the idea. And if you ask all three patients, no, they are just have a bit of skin that never heals. It doesn't bother me, not painful. I try everything under the sun, Fusidin, polysporin, you name it, Betaderm, and you know. All right? Again, bump my head, it never healed. Squamous cell. Again, something that always scabs but never healed. You have to keep a high index of suspicion, okay? And you might ask, Dr. Leung, why not the psoriasis on the left? No, psoriasis never scab like that. The scabs are not that thick and dirty, and psoriasis scales are never bloody. Remember the auspice sign, whoever was there yesterday? They are nice, silvery, and it only bleed when you lift off the silver scale. In itself, it never kind of, become that dirty and bloody and pleomorphic. This I actually showed yesterday. This lady have a lot of venous stasis, and been treated venous stasis and dry skin for a long time until she came to me, and then she said, well, I've got this little two bugger that never goes away, really hard lump, and I always scratch it and bleed. Okay, and the other lady, on the other hand, of course, have this, and they said again, well, I've got this spot that never heals and, bleeds, and both are squamous cell. This is Bowen's. The lady on the left actually has a pre-squamous cell, not to squamous cell in situ, but it's Bowen's. Bowen's is a term intermediate between advanced actinic keratosis and carcinoma SCC in situ. You call it Bowen's. Right, dermatoscopy. See how angry, how nasty it looks like. So it would be a fantastic world if you learn to use dermatoscopy. It's almost like a mini world you peep into when you use it. Okay, so no problem seeing that, right? Hyperkeratosis, and the scabs and things. Now, how about this? Sometimes when I strike a very good relationship with the family doctors, they send some referral and then they say anthrax. Wow. I almost kind of want to don a full kind of protective gear. Anthrax. Yeah, well, I understand. Black and bleeding and a little sore. But interestingly, patients have another one on the hand, on the arm. So when you ask about the patient, the forehead and the arm, they are the same, and probably due to insect bite, I kind of, scratch it, and they kind of get bumpy, but it's kind of ugly. And I asked him, is it painful? No, no. So it's keratoacanthoma, SCC in situ. Now, the paradigm has swung to the other side and treated proactively as an SCC. Before, let's say 12, 15 years ago, keratoacanthoma is considered as a benign lesion. But now, if you ever diagnose keratoacanthoma, the plastic surgeon has to step in and cut it out, okay? All right, melanoma now. So melanoma is the uncontrolled proliferation and spread of the melanocytes, and the third most common skin cancer, according to statistics, and a high tendency to metastasize. 5-year survival is never 100%. So you do hear this awful horror story that people undiagnosed melanoma, they died because of late diagnosis, metastases. And accounts for 75% of death due to skin cancer. So it's the majority of the killer. Now there are 4 main types of melanoma: the superficial spreading, the nodular type, the lentigo maligna I talked to you about. Remember the man with a little shaving bump there, okay? And acrolentiginous. The 4th one is the most surreptitious one, which is not pigmented. It's actually hypopigmented. It's white. It's kind of like a nasty ulcer, grow on the fingers, nails, and they kill people. Acromelanoma. So beware of that. Now, call it the diagram again, and we'll talk about this little white guy. I don't know why this diagram is only just white, but it should be a line, a lot of melanocytes lining the dermal-epidermal junction. And when they go haywire, then, of course, they spread. See how close they are to the dermis and the blood vessels. We all know about ABCDE and EFG, right? So whenever a patient question or asks you, how can I make sure that I have no melanoma, then you say the ABCDE, the asymmetry, whether it's asymmetrical, whether it's a border, look at the color, there's any irregularity, diameter. Don't ask me how, by statistics, more than 6 centimeter, sorry, millimeter, a mole, that is something to be concerning, but it's evolving in size, shape, color, edge, and bleeding. And then the EFG, the mnemonic, is about elevation, firm, and growth, is for nodular melanoma. So ABCDE is the one mnemonic you carry around. I've shown this before, those actually came before. So tell me which side are bad, which side are good. Easy, eh? Left side good or left side bad? Bad, raise a hand. Yes. You can see they're ugly. You can tell, right? Difference in color, no, spreading, 2 different shades of color, especially the third one, and then spreading. The other guys on the right side, they are all good. They are either kind of what we call fibrous papilloma, strawberry nevus, skin tag, okay? But I'm not God, of course. Sometimes I need my dermatoscope to confirm. Wow, this one. What would you say? Yeah, I wouldn't be too comfortable sitting on it. Okay, especially history used to be one mole black, but then the other part just grew. Yin yang, right? So not good. The other one also, Shirley is a young chap, and then he said he bicycled like 20 kilometers a day, and only wearing shorts. And he said, I definitely have a mole the size on next to it, and now it become like that. So both are nodular melanoma. Patient just walk in with this, okay? A changing mole. So you can see all the features, okay? The one on the left, a little spin-off lesion, satellite lesion, irregular edge, no symmetry. Plus, I'm going to introduce you to the veil sign. The light gray purple light gray kind of hue on top of that is called the veil sign. It's almost 80% diagnostic for melanoma, okay? The one on the right, okay? Again, because of the pleomorphic kind of, features and different domain, It's invasive, okay? So we can see now. One other thing, if you learn to use dermatoscopy, you also pay attention to the erythematous hue, the erythema around it. Your body, the patient's body is trying to heal, trying to react, trying to cope with the melanoma, and it starts a kind of like a futile battle against it. So that's why it's red. So if you have a mole that's suddenly gone kind of funny in shape, size, plus a bit of erythematous ring, I bet you my $2 that is going to be a melanoma. Now, again, a very diligent family doctor colleague asked me to biopsy the root melanoma. Shall I do it or shall I not? Say yes, hands up. Say no, hands up. Why no? Shout out, come on, 20%. I need to fulfill the quota. Huh? Sorry? Margin, yeah? Okay, yeah, good. Hair, yes, a hairy sign, thank you. Dr. Leung called it the hairy sign. So if you have a hairy nevus, this is actually a hairy dermal nevus. If you actually see a nevus with some hair, well, probably you can stand on safe ground and tell the patient, yeah, come back 6 months. All right? I actually have a guy with a ginormous hairy nevus covering his deltoid area, measuring 20 centimeter by 20 centimeter. And it's so hairy, he has to shave it. And it's so dramatic, but it's normal. Okay? The hair sign. Right, how about this Jew? What do you think? Mole that bled. And this one, mole that dissolve. I asked the patient particularly, are you sure they have just, are they all one? No. He said, no. Only one. It just spread like, when I play the pool, all the balls just spread around, just like that. No good, eh? You can see the mole that bled is a nodular one with a erythematous ring. All right? And this is superficial spreading melanoma. Don't underestimate that. When the patient walks in like that, ask for the history. The patient sometimes is so vigilant, they said, no, it's not like that. Even better, ask the patient to show you a picture. If a picture shows that the mole is not like that, it's being scattered, please. You do a biopsy or send to your nearest dermatologist, a focus practice dermatologist, and do a biopsy and lose no time, please. Now, a mole that gets darker. Do you biopsy or do you not? First of all, is it a mole? Anyone? Come on, 20%. Help me do the 20%. Yes or no? Yes? Oh, yeah, okay, fine. But it's a bit bumpy, eh? It's like a dry raisin. I would classify it as a skin tag, right? Acrocordon. Anyone know that term? A skin tag, okay? It's a pigmented skin tag. Now, the one on the left, I'm pretty confident I left it behind, but the one on the right, I'm a bit on the fence. You know why? Like a little crystal ball with 3-4 things inside and swishing around. So I end up, kind of, do the biopsy. I thought the one on the right is a melanoma, but I, of course, pleasantly surprised this is just an intradermal nevus. All right, even I have my doubts sometimes, so I do my biopsy. I do a shave biopsy, okay? I don't normally cut and stitch. Now, again, this young lady came in, said that she had this mole, but definitely it was like a small one, but spread. Even at that distance, this is not something good, right? Yeah. Wow, look at that. So spreading, and you can see actually 3 different types of color. The nodular domain become spreading, and then you also have the hypopigmented area, right? The melanocytes actually spread so quickly, they don't even bother to put on their dark coat. They are white. So it's a PT1B, invasive melanoma. Without ado, within 3 days, I sent her to the hospital, and she had a wide local excision plus lymph node, and she is happily surviving. Right. I talk about having a mole more than 50 years is not a guarantee. That's exactly what happened. This gentleman says that, I have a mole, but it's round, and then it starts to get, some bleeding, and it's painless, and I don't know what's going on. I might be bitten by a mosquito. I said, hang on, let me look at it. Nah, not good. Look at that. Scab, and then it's kind of erythematous base. And it's a nodally invasive PT2B. Don't ask me about PD1, PD2. Roughly, it's the thickness, 1A, 1B. B is with ulceration. A is without ulceration. 1, 2, 3 is about the thickness, Clark's thickness. So I'm no specialist, but this is roughly I know. And the prognosis also, of course, depends on the PT, the TMN staging, they call it. This gentleman is an overseas student, came in with no OHIP. And he said, well, can you check these 2 moles for me? His English not too good. And I said, all right, fine, I'll check for you. But what's the history? I said, no, they get darker, especially the one on the right. Definitely not without the rim. I said, okay, let's look at it. And lo and behold, I am not happy. You know why? Can you see the one on the left? They have the reticulate kind of formation like network. The pigment is spreading. And the one on the right, you have this melanin granule, like troops actually, standing at the border trying to invade. So these are the 2 things that actually describe clearly reticular formation and melanin granules. These are the omnivorous sign. Both came back as invasive melanoma. End up this patient hasn't got OHIP, so he has to go back to his hometown to have it done. 18 years old. How about that? And when I asked him, he used to work in a farm with his father, and God knows how much sun exposure he has. Nails, yes, melanoma. Don't forget about nails. Okay, so who think that the melanoma, which nail has melanoma? Shout out. 1, 2, 3, 4. 1 is the top left. Second, bottom left is 2. Top right is 3. Bottom right is 4. Who will say 2, 4? Or 2, 3? 2, 4? How about number 3? The one in the top right. Or actually, how about the first one? What's different about the first one? Is it black? No, what color is it? Green, eh? I actually wrote a paper on it. Okay, if someone be curious, look at BMJ. Is it the case study, something like that? Someone with 10 green nails is Pseudomonas. Pseudomonas. Only one thing that can infect your nail with green color is Pseudomonas. And you just use some ofloxacin, either oral or topical, put it under the nail. 3 weeks, I bet you my tune it will go away. Okay, one out. How about the other? Which has, one is subungual hematoma. Which one is subungual hematoma? 4, great, yes. And these are the 2 melanoma, okay? Subungual hematoma causes a lot of concern. Many a time I have to, check and see, for the patient, reassure them. And the best thing is to ask them to come back in 3 months. You can see the whole thing just move out. Melanoma, look for the Hutchinson sign. Anyone knows this Hutchinson sign? Involvement of the dark pigmentation in the cuticle area and even beyond. All right, Hutchinson sign. If you ever see, don't judge by the color of the nail. The depigmentation can be stripy, can be thick, but it doesn't matter. As long as you have it really backwards from the cuticle, from the matrix, then you have melanoma of the nail. But honestly, thank God, I haven't done that many biopsy of the nail. It's so brutal. Interesting. Which one is melanoma? 1, 2, 3, or 4? 1 is melanoma? No? Okay. How about 2? Easy. You see a lot in your clinic. Painful walk in. Number 2. The one bottom left. Ingrown toenail, yes. Number 3. Have you ever seen it? Ugly little thing that grow on top. A parasite or something? Yes, it happened. It's not melanoma. 1 and 4. Destruction of the nail plate and also total destruction. You have the acrolentigenous melanoma. See, the number 4, the melanoma cells actually so white, it actually, so fast it actually destroyed the cell. So investigation, dermatoscopy, biopsy, lymph node sampling, PET scan, whatever, depending on the staging, as biopsy is very important. And actually by surgical excision, skin grafting, chemotherapy, radiotherapy, so forth and so on. Now, others. I'm going to show you the others. A little strawberry on the lip. Or elderly lady, fell all the top topical. This is keratoacanthoma. Not to be kind of mistreated. It has to go to a surgeon to cut it out because it's a carcinoma it's SCC in situ. Firm, red, like a little kind of blueberry, but it's red. This one, sometimes you see in singleton DSAP, family history, not resonance Lamisil, and this one hopefully you won't see. This is a T-cell lymphoma. Anyway, all right. Something that you might actually see more often, okay? So cancer. Is it cancer? Blue nevus. Now that one takes a lot of guts and experience to diagnose. It's so blue, you have to really use a dermatoscopy to diagnose, and it's benign. This one is a compound dermal nevus, but be careful. Sometimes if the pigment dissolves backwards onto the base, then it can be melanotic. And the third one, it's my jam. Again, I published a paper on it. It's a sebolith. What is sebolith? It's a sebaceous cyst that actually got dried and the punctum opened and become dry like a stone, and it's slightly painful. And a lot of doctors say that it's cancer. No, it's not. Literally, you can anesthetize the skin, get a little cut, fish out the stone, and end of the mystery. Sebolith. Now, this girl, SCC, a girl with SCC. Wow. Okay, when I see this girl is actually not communicative, downcasted, and have a repetitive behavior. And then not to kind of, pay attention at home. And then next thing I knew, she keep on scratching. And it's actually dermatitis artifacta. This is not SCC. All right. Good old friend, exclude malignancy. Anything brown and ugly and palpable cause a lot of concern. But I bet you my $2 again, you will see more seborrheic keratosis than a melanoma. Seborrheic keratosis is typified by dry skin, sometimes, greasy, all over, okay? And this, how can it be malignancy? What is that? Keloid, right. No, it's not. Sorry. Just checking. How come I got this seborrheic keratosis? It's keloid. Anyway, someone changed my slide. It's keloid, sorry. All right, okay. Now, how to diagnose? Good history, again, take a good history, whether it's acute, chronic, any change. Detailed examination using magnifying glass to find out what's going on, and then better still use the dermatoscope. Look for asymmetry, look for evolution change from the history, any ugly, dark new changes in color or loss of pigmentation, irregularity in border, satellite lesion, loss of normal structures, contact bleeding. These are the omnibus sign. And then systemic causes sometimes can cause. Typically like hidradenitis suppurativa, you can get multiple boils, but you just have to really look carefully. Use the dermatoscope if possible, and then biopsy. And consider trial treatment, which can do some antibiotic and then moisturizer, and to a limited extent, 2 weeks up to 2 weeks of steroid, please, not 2 months, not 2 years. And same applies to antifungal. 2 weeks is enough, not 2 months, not 2 years. And then refer when you have a focused practice dermatologist around and you're blessing, send it to us, and we'll be more than happy with a clear description, and then even FRCPC dermatologists. And the tools, of course, these are the basic tools. wood slam, dermatoscope. And finally, a reminder, not to be disrespectful, don't just blindly give steroid. Please, this is almost your self-placebo. Tell the patient that you haven't got a firm diagnosis, the differentials are possible, blah, blah, blah. They appreciate it, and then you're going to do more biopsy, or you send someone to do biopsy. Doing all the quadruple cream is not going to gain you anything. And then better do nothing. Better nothing means just give them some moisturizer, or do biopsy, or refer. Now, another kind of list of a boy will not respond to 2 months of Fusidine, Triderm, Betaderm, and it's painless as it's bleeding. Okay, so it's basal cell. Look carefully for the telangiectasia. Oops, I got it through. Another family doctor who learned a bit from my correspondence, and they say, it's a Bowen's that bleeds. And I said, okay, let's see, bleeding, well. And then can you see what's not Bowen's? You see all those coral fingers sticking out? It's a classic telltale sign of verruca. Only one skin condition gives you this tremendous finger thing, keratin, filiform structures. Because patients scratch it, that's why it's bleed. And I prove it by using one cryotherapy, 4 weeks come back like that, almost clear. It's an irritated verruca, a wart. Perioral dermatitis in an elderly. Please, before you pen it down, think about why on earth would she have perioral dermatitis. She's gone past the age of rosacea, acne, whatever, okay? But why? And if you take a good history, it's painless, it's just a little red patch, and it's not kind of, responding to, normal things like Betaderm. So when I look at it, it's actually a Bowen's disease. Very common in sun-exposed area, the lip, okay? Okay, what do you think? Are they SCC or BCC? Shout out. 20%, please. Basal cell, hands out. Yes, you got it, basal cell. Because basal cell usually are more kind of organized, and you can see the second one actually have a bit of kind of roll-up edge, okay? It's tricky. The fourth one is actually a spreading basal cell. So only proved by biopsy. Now, obviously, shaving wound not heal 4 months, and this one has a 6-month-old insect bite. Basal cell or squamous cell this time? Squamous cell, yes, because it's so irregular. And don't underestimate a little point kind of, scab that doesn't heal. Yeah, you see that a lot, right? Awful. Okay, the one on the left is actually seborrheic keratosis with a pinch of salt. He came in with that red patch. It's actually a Bowen's disease buried inside a squamous cell. Buried all this seborrheic keratosis. So I end up has to biopsy and send him. But the one on the right, whoever got it will get a bonus. Do you know what's the condition on the right? Indians origin, even Chinese origin, have a painless eruption of these dark macules. Ever heard of lichen pigmentosus? Yeah? Treatment is topical corticosteroid or oral hydroxychloroquine. It's a systemic autoimmune skin condition. Refer to me, query cancer. Ever seen a patient growing a horn? I was wondering, when those in the medieval ages were witches burned on a stick, sometimes they get this condition. In fact, it's a cutaneous horn, okay? It happened, okay? When the actinic characters somehow go haywire, so focal, and it stack up the cells to the point that it becomes a cutaneous horn. It's actually a SCC in situ. Melanomas? Yes or no? Yes, all are melanomas. Lentigo maligna, and then the others are, different color and shapes. Now, last but not least, no response to Fusitin cream. Which one you worry about? Left or right? Right? Left? Left? Yes, left. Left is acrolentigenous melanoma, not even dark. It's destroying the nail plate, it's painless, it's bleeding. The right is pyogenic granuloma. You see it quite a lot. When you have a little splinter, the patient gets painful and then start to bleed and very awful. It can be treated by high hybrication. Finally, again, that my beloved family doctor asked me to see this patient. And they say, oh, it's a dermatofibroma, please excise. He must have learned a lot from me. And I said, okay, let's have a look. Let's have a look. What do you think? Yes. Look at it. Exactly a miniaturized 1 to 10 kind of, it's accessory nipple. Happened in male too. So thank God that I did not actually kind of, do it. Anyway, thanks very much. I went over one minute. Time for questions. All cleared? There's one question.
Hi, thank you so much
Hi.
for the excellent talk. You sort of brushed on biopsy.
Yes.
And then I was sort of wondering, like, for the SCCs, for the BCCs, also for the melanomas.
Right.
I love my shaves. I don't know if that's always the best sort of option for a biopsy. I was wondering sort of what are your recommendations for the biopsies for the BCC, SCC, and...
To be honest, I don't make a difference. I actually, if I'm pretty sure it's a melanoma, I would certainly do a punch biopsy. Especially, I would traverse the edge in order for the histopathologist to see how much is spread and the thickness. And I usually do a 6 mm punch, make sure that I get enough of the tissue because they will report on the thickness of the melanoma. But if it's basal cell SCC, sometimes I can do with shave. That's a very good question, yes.
Okay, cool. And then so like if I were to shave it, if it does come back SCC, BCC, like with margins positive or whatever, I can just refer to...
No, if I do a shave, I also bear in mind that I would like to not need to do a second procedure. So I actually leave at least 2 mm of the margin, okay? And it's a technical finesse to use the shaving blade in order to shave it. But yeah, I think the shave biopsy, when I do it, I will certainly bear in mind at least 2 or 3 mm of the edge.
Okay, so
and,
try to excise.
Yeah, and knowing that BCC never metastasize, SCC sometimes, but melanoma, I usually do a punch.
Okay, awesome. Thank you so much.
Thank you. Hi.
Hi, thanks so much for a great presentation. I'm just wondering in what situations you decide to treat with Effudex for basal or squamous rather than referring for full excision?
Very good question. If the patient is, in residential home, being kind of challenged by traveling to hospital, and also I discuss with the patient whether he or she like to have the skin taken out. Of course, I encourage them to have it removed as much as possible. But sometimes, like an intermediary procedure, I would try them on the Effudex, and then we'll reach a contract, say, okay, I'll try on some cream first, and if it doesn't work, you have to go to the plastic surgeon to take it out. Usually it works well. Mainly it's because of the conservativeness of the patient doesn't want to have surgery on the face, on the ear, whatever. Yeah, thank you.
The same question, if Effudex is a safe approach as a first step?
Yes, it is. But you have to demo it. Usually when I use Effudex, even for actinic keratosis, I ask the patient to come in, and then I show them how to put on it, and exactly the amount, and then how to spread it. So, but for the lesion, I will also demo it. Okay, use a Q-tip, and then use the minimum amount of the cream every night for 4 weeks, and then come back in 4 weeks. Yeah, I never really prescribe and then let them use it, knowing that there is a high chance of error when they put the cream either too much or too, not enough.
If a dark suspicious melanoma, is it safe to do the scraping
shave?
biopsy, shave biopsy?
As I just answered the other doctor there, if a melanoma, I usually do a punch biopsy. And that will actually be more beneficial because the histopathologist need to report on the thickness, the Clark's, and the TMN. So if I shave, sometimes I cannot actually get to the bottom of the lesion.
Would you ever use an excisional biopsy if you think it's a melanoma, if you think you can get around the edge?
Excisional, yes. But call it me being lazy, and sometimes I would rather kind of do a punch biopsy first because I know that I have a good person to fall upon. And sometimes I'm just worried that if I am unlucky enough to have something which is thicker than I thought, and then if I cut it up, I thought I got enough clearance, but in fact, patient has to do for another one, which is not good. So I would rather do a punch. Yes.
Punch is
Thank you.
safe in scalp?
The scalp, yes. Scalp is also my enemy. I don't like punching the scalp because it bleeds so much. But as much as I can, do it, then I will just try to do it as much as I can. Maybe, smaller, like 4 mm, 3 mm. Use lidocaine with epinephrine just to stop the bleeding. Because this is very difficult to stop bleeding. Thank you. Okay, thank you very much.